Oncology Club is very proud and happy that from the very beginning of COVID, we are using this time of social distancing to an era of social connecting. So we have been arranging multiple programs and we are almost touching 100. And as a part of that sequel, every week we are doing this oncology session. So today we are going to have our program on standard of care for resectable local rectal cancer, the role of CTRT, patient selection therapy course. So this is a 1-hour program and it will be presented by one faculty. Then we will have some specific question answer session, and we will appreciate that our junior will participate most in the question session. Today, our academic partner is Equivida, Bangladesh. So let me introduce today's faculty, Dr. Mostafa Aziz Sumon, who is the Assistant Professor and Head of the Department of Oncology, Kumatora General Hospital. We treat him as one of the most promising oncologists of our country. The most important insight about him that he loves to go deep into any issue and he enjoy explaining tough thing easily. And he take interest in radiation therapy. Welcome to Sumon. And today our overseas guest faculty is Dr. Sharupa Mitra, who is the Senior Consultant and Chief of Gastrointestinal and Genitourinary Radiation Oncology of Rajiv Gandhi Cancer Institute Research Center, New Delhi, India. Oncology Club is very proud to have a prestigious center like Rajiv Gandhi Cancer Institute as their academic partner. How can I forget the enormous support of this institute at every step by their continuous support on our ongoing journey. A big thanks to Sarupa for supporting our recommended fellow, Dr. Arman Reza Chaudhary, in the virtual fellowship program of UICC. Without your support, he couldn't have done it. And now he is a proud certified virtual fellow of UICC. Thanks, Sarupa, for all your support. Move to our presentation. Our president, Professor Emil Haisar, is always a support for us, and he is always an inspiration for us. As per custom, always we start with his blessing. Unfortunately, he will be a bit late, but as you know, he is very pertinent about time. So he suggested to start our program, and he will join us later. So now, without wasting any time, I would like to request Dr. Mostafa Aziz Sumon, today's presenter, to make his presentation. Sumon, over to you.
So thank you. So thank you, Dr. Kano, sir, for those kind words. So today's my topics is the management of resectable locally advanced rectal cancer. The role of radiation therapy, chemotherapy, how we are going to select our patient, so what should be the radiation therapy course. So if you see the slides, so you can see, so this is the formula. Most of us who are present here, you are very familiar with this formula for rectal cancer management, chemoradiation therapy, followed by surgery in any form, total mesorectal excision right now considered the standard of surgical care, followed by chemotherapy. So this is more or like a formula that is 2 + 2 = 4. This is just simple like water. But in the real world, so this formula might be the most toughest scenario of oncological management. The question is why? As you can see, the first part, if we want to give the radiation therapy, now the question will come, why we are going for radiation therapy? Is it really needed for going to radiation therapy? Is it going to give any benefit just in consideration of locoregional recurrence, overall survival, etc., etc. So if we decided to give radiation therapy, again this question will come, should we give before surgery or after surgery? So again, there is a question. So consider that we are in favor of giving radiation therapy. Again, there will be a question. So what would be the radiation therapy mode of delivery? Would it be short course or long course? Short course means 5 in 5, 1 week completion. Long course means continuous treatment around 5 or 5.5 weeks. So still there is a dilemma regarding this selection of radiation therapy. And again, I have already discussed that the role of radiation therapy, whether we are need this radiation therapy always, irrespective of locally advanced rectal cancer patient. So come to the first part, the chemotherapy. You can see there is a question: do we really need this chemotherapy along with radiation therapy? If yes, what should be the regime? Is it 5-FU, continuous, bolus, or capecitabine? So do we really want to give this chemotherapy always neoadjuvant, or there is a role of this chemotherapy as adjuvant? So there are lots of questions. Assume that we have all decided to give concurrent chemoradiation therapy. Now again, there is a dilemma regarding the interval. So you have completed this chemoradiation therapy. Now, when you will do the surgery? Is it after 1 week, 4 weeks, 8 weeks, or later? So there are lots of unanswered questions lies between this line area. So we have done this surgery, that is the total mesorectal excision. Again, there will be a question. So is there any role of this chemotherapy adjuvant? Is it really necessary? If my patient doesn't want to get this chemotherapy, actually what he is going to miss, what this adjuvant chemotherapy is really going to give to this patient. And again, the most important topics in 2021. So do we really need this surgery? Is it avoidable? So you can see the simple equation right now is not appeared as simple as it was in earlier. So there are lots of questions lies in this picture. So why all these questions? Because the most important two issues. So whether we are going to overtreat my patient, or the patient is going to get under treatment. So if you are avoiding some part of this treatment, consider you are going to straightway the TME and don't offer any further treatment to your patients, and the patients might come with recurrence 2 years. So you might started to think that I should give some chemoradiation therapy. So you are thinking about under treatment. But again, if you are treat your patient with chemoradiation therapy, TME and CT as per the protocol, and the patient after 2 or 3 years comes with a severe toxicity, intestinal obstruction, you need a diversion ileostomy just only to avoid this post-operative additions. So you might think, is there a need of this additional treatment, that is CTRT? So there might be a very few questions that should be answered properly. And let's see how evidence help us to solve those questions. So since 1986, we know that TME is considered as the surgical standard of management. But you can see the only TME, what we have expect as an outcome. The 10-year survival, stage 1, 72%. Good. But still, 28% in stage 1, we are missing. Stage 2 and 3, 55, 37%. So TME alone is not enough. We can see from this slide. So what we can do? So question number 1. So if a very good TME is done, so is there any role of this perioperative treatment in the year of 2021? Let's see. So this is the Dutch TME trial. They have tried to answer this question with a good TME with a more than 1,800 patients, stage 1 to stage 3 patients, 1 arm TME. Keep it in mind, this is a European standard TME, very good TME. And another arm, short course radiation therapy followed by TME. So they added short course radiation therapy before the TME. And what they have found, you can see the red line, the surgery line, and the blue line, the radiation and surgical lines. So you could find that the red line is higher than the blue line. That means that the TME alone outcome with higher local regional recurrence. The short course radiation therapy succeeded to pull the line a bit lower. So finally, they concluded with 10 years follow-up that the local regional recurrence rate is quite low with short course radiation therapy along with TME. So we can got our answer that the local regional recurrence rate, yes, short course radiation therapy along with TME reduce the local regional recurrence rate. But unfortunately, that the 10 years data failed to show any overall survival. So from this slide, we can get a conclusion that even in 2020-21, if a patient presented with a good TME surgery, still there is a role of perioperative treatment. Answer is yes. Now come to the second question. We have decided to treat our patient with radiation therapy. So when we should give this radiation therapy? Before surgery or after surgery? So come to see. So let's go back to our past, the glorious past. This is the NSABP R01 trial. So they have tried, after a radical surgery, they have treated with radiation therapy. And at 5 years, they found that the disease-free survival, that means the local regional recurrence rate, it is statistically significant. But in the survival context, no survival. So after surgery, giving radiation therapy, going to give you a better local regional recurrence rate, but ultimately no overall survival as per the NSABP R01. So this is the inference from R01, reduce local regional recurrence rate, but no role on survival if you are going to give your patient radiation therapy after a radical surgery. So here comes the Swedish group. As you know, the Swedish are considered as the most compatible groups treating rectal cancer, and they are very famous for their rectal cancer management. So you can see the Swedish group, NSABP tried post-operative. Here they come with a good mind that they will offer radiation therapy before surgery. And they have give the radiation therapy in 5 into 5 fractions pre-operative. And you could see the total intention to treat group, 7 years, 8 years, 9 years, overall survival, not local regional recurrence. You can see there is this very gap between these lines. So Swedish group proved, published in New England Journal of Medicine 1997, better overall survival by pre-operative short course RT, 5 into 5 fraction. And it was evident in every stage A, B, C, and it was considered a few years ago. So when Duke's stage was considered. So the Swedish group established pre-op RT 10% survival benefit in overall survival at 5 years. So as the Swedish group came forward, the German cannot sitting idle. So the German group came forward. So unlike Swedish group, they have tried to treat long course radiation therapy, not as like the short course radiation therapy like the Swedish group. And here you can see that around 800 patients, stage 2 to 3, they have randomized in 2 groups, first surgery, then long course chemoradiation therapy followed by adjuvant chemotherapy, and in another arm, long course chemoradiation therapy followed by surgery, then adjuvant chemotherapy. And again, you can see that the blue yellow line, that is the neoadjuvant concurrent chemoradiation therapy. That means delivery the chemoradiation therapy before surgery. The local regional recurrence rate is lower than the blue line. That means the post-op chemoradiation therapy. So even with chemoradiation therapy, pre-op modalities is better than post-op treatment, considering the local regional recurrence rate. But again, it fails to prove any overall survival difference. So we are really concerned about the toxicities. So regarding the pre-op, post-op issues, you could see that the Swedish group proved some overall survival benefit. NSABP and the German trial both proves that the pre-op RT, German trial proved that the pre-op RT provides better locoregional recurrence rate, but no overall survival. But what about the toxicity? Because the radiation oncologist point of view, we are really concerned about the toxic issues. The German trial proves that the less acute and long-term toxicities if chemoradiation therapy is delivered before surgery. That's the very interesting topics. That's the very important findings. That giving chemoradiation therapy earlier, less toxicities. So now come to conclude the discussion regarding these topics. Radiotherapy should be delivered before or after surgery. With all this discussion, NSAPP 1, Swedish trial, German trial, we could conclude that the before radiation therapy produce as well as good locoregional control, as well as overall survival, but with a less toxic profile. So our decision would be give chemo or radiation therapy before surgery. Now come to our third questions. What are the standard preoperative treatment regimens? So in this area, I am talking about the ASCO 2000 before the era of ASCO 2020, because that year is considered as the game-changing era regarding the rectal cancer management. So you can see that giving your patient a preoperative treatment in this time, you have three options. There's the long course chemoradiation therapy, 50 gray along with capecitabine or 5-FU, and you have to wait 6 to 8 weeks, then surgery. One options. Another options is the Swedish trial, like this 25 gray in 5 fractions, and go for surgery less than 1 week. And another options, 25 in 5 fractions, and you can wait 4 to 8 weeks and surgery. So among these three, you have to pick one with rational and logic judgment. So let's see how to pick one. So the trans-Tasman group, the Australian groups and the Polish groups come forward to find out a decision regarding these issues, whether short course versus long course. So you can see the trans-Tasmanian groups, they took T3 in positive groups, and they have tried short course versus long course. Primary endpoint, locoregional recurrence. No difference in locoregional recurrence. Same to Polish trials. They have taken a more bad case than the trans-Tasmanian groups. You can see the T3, T4, and mid and lower groups. As you know, these groups are then this therapy. So the locoregional recurrence concept, long course versus short course, are very equal. So what about the overall survival? Again, no difference between these two, long course versus short course. 5 years, 6 years, 8 years, no difference. Both in the trans-Tasmanian groups and the Polish groups, there is no overall survival difference. So we could easily consider the short course versus short course rather than the long course. But the story is not end yet. Regarding the toxicities, yes, we are very concerned when we are giving 5x5. We have a preset mind that the 5x5 might get severe toxicities. But you could see the two trials analysis shows that more than grade 3 toxicities are almost same. So there is no difference between the long versus short course radiation therapy. But we need to keep it in mind that in a country like Bangladesh, where we have resource limitation, where we have financial limitation, if you are going to treat your patient in government hospital, 5x5 might give a 40–80% more chance of getting more treatment. And if you are going to treat your patient in a private hospital, you are going to reduce the cost of the treatment around 80%. So short course treatment might be the area of discussion in Bangladesh concept. So Probably in long course versus short course, there is no difference in local regional recurrence rate, overall survival, toxicities. But you could see finally they have found some difference. What is that? That in the trans-Tasmanian groups, you could see that the blue lines, that the PCR is only 1%. Short course, but in long course, it is 15%. In the downsizing issues, the short course 28% and long course 45%. It is also reflecting the Polish trials. You could see that the short course R1 resection 13% and the long course 4%. So actually what this means? This means that the long course resulted good downsizing as well as RO resection. So if you are treating a patient with a low-lying tumor invading the sphincter, so you need a good surgical outcomes. You want to spare the organs. So if you are really thinking about the downsizing, you should think about the long course. If you really think about the local regional recurrence overall survival, there is no difference between this arm. So we need to very cautious about selection of this protocol, keeping all these limitations and all those advantages. So long course CTRT is the preferred option when tumor downsizing is needed as per those two trials. So with the short course radiation therapy, surgery within 1 week, the most limited outcome was complete pathological response. So here comes the Stockholm 3 trial. They have tried 3 options: the short course radiation therapy with surgery 1 week, and short course radiation therapy surgery, and they tried to delay a bit 4 and 8 weeks and to do the surgery to see whether there is a change in the pathological response rate. And very interestingly, you could see the pathological response rate in the delayed group is 27%. So even in the short course group, which was divided, which was criticized by their low PCR rate, here you could see the short course radiation therapy, and if you give a space between this radiation therapy and surgery, you could expect a better pathological complete response rate. So even with short course rate, you can think about what an end-weight policy. So what are the standard preoperative treatment regime? After the trans-Tasman and Polish trial analysis, we could easily say that long course chemotherapy, long course with chemotherapy, or short course radiation therapy, equivalent results irrespective of local regional recurrence rate, overall survival rate. But if you really need to downsize your treatment, downsize your tumor, as well as you are expecting a good pathological response rate, you should look for the long course. Question number 4. What is the best timing of surgery after long course chemoradiation therapy? Is it after 1 week, 4 or 8 weeks, or more than 8 weeks? Let's see. So you can see the very findings. So after the long course treatment, you can see that took about 5 or 6 weeks. After each week delay, there is increased pathological response rate. So from 6 weeks to in every week, you could see that the PCR rate is jumping. And the 14 to 5 weeks, you could see they reached a plateau. And after that, there is no pathological response rate. So considering this fact, probably this is the time when we should do the surgery to get the maximum pathological response rate. And that is the 14 to 15 weeks. That means after completion of the chemoradiation therapy, 6 or 8 weeks is the standard of treatment for getting maximum pathological response rate. But in the US national database, you could see the patient's number is more than 6,000. Here you could see, as like the DAS database, the more the delay, more the pathological response rate. But on the other hand, they found a very interesting feature. The more the delay, more positive surgical margins. So for me, the chance of positive surgical margin is 9.7%. So we need to counterbalance between these two. And with all this information keeping in mind, the consensus 6 to 8 weeks after preoperative treatment, even if you have treated your patient with long course concurrent CTRT. So 6 to 8 weeks is the standard duration. Question number 5. Is there any role of our adjuvant chemotherapy after preoperative treatment? Here we are very familiar after the surgery. We are favors to give our patient advice of adjuvant chemotherapy. Now see, after concurrent chemoradiation therapy, surgery, the patient already exhausted, and now we are prescribing our patient a 6 months duration of treatment, costing about 4 or 5 lakhs, even with the Xelox protocol. So is it really worth the? Let's see. So these are the trials you could see. They have tried to find out this answer. All these trials, you could see in the 5 years overall survival rate, no difference. You can see the hazard ratio is almost all are equal to 1. So 5-FU-based chemotherapy as adjuvant after CTRT surgery, there is no role in overall survival context. But you can see, so this is the ADO trial that presented by the Korean group, and that's why the Korean are very, what I could say is a loving character, particularly for the medical oncologist group, because they have established some role of medical oncology in the rectal cancer management after chemoradiation therapy. You could see in the ADO trial, after the concurrent CTRT, after the surgery, if pathological specimen comes with pathological T3-4 and there is a pathological node, keep it in mind, after radiation therapy, if the surgery done, and you can see that there is not an optimum response, pathological T3-4 or N positive disease, they have tried with leucovorin 5-FU with FOLFOX. And adding this oxaliplatin, you could see they have found a better disease-free survival. There is a local disease-free survival advantage, and it is evident in all pathological stage group, and it is also evident in the intention of treat group, and the hazard ratio is 6. So this ADO trial proved some benefit, but keep in mind it is a stage 2 disease. The patient number is only 321. So this study is really criticized by the German PETAC trial because there is a number of patients, even with adding oxaliplatin, they did not find any overall survival difference. But we can keep it in mind that adding oxaliplatin to these poor responded groups might be an option. Definitely, adjuvant treatment is not for all patients, those who are treated CTRT and TMA. So this is a very interesting, what I could say, very informative flowchart. So if locally advanced rectal cancer patient, you have treated your patient with a good standard chemoradiation therapy followed by a very good TMA surgery, look at the pathological specimen. If it is not a good respondent, pathological T3, T4 disease, not positive disease, you can consider this adjuvant chemotherapy, but patient complaints is a factor. So you need to check whether your patient is a fighter and he is ready to accept this 6 more months chemotherapy only to get this 4 to 6 or 8% 3-year disease-free survival gain. If it is not, stop over here. And if the pathological good respondent, no question about giving adjuvant chemotherapy. So we should keep this information in our mind before selecting adjuvant 6 months duration chemotherapy after CTRT and TME. So come to the consensus. Is there any role of adjuvant chemotherapy after preoperative treatment? Result is still uncertain. And if you want to give to our patient, we need to discuss the pros and cons of this treatment. So within the last 40 years, we have, with all these trials, with all those informations, still the real headaches in rectal cancer management is distant recurrence. So still we are failed to achieve a significant result in this area. So how to address this distant recurrence issue? So as you see, the cost of adjuvant chemotherapy did not result in a good outcome. And the problem is systemic relapse. So why not to try with some chemotherapy before surgery? So that is the main concept. So here you can see the PRODIS 23 trial. They have tried stage 2 to 3 cancer patients in one arm, long course chemoradiation therapy surgery, FOLFOX treatment. That is very standard treatment that we are actually practicing. And another arm, 6 cycles FOLFIRINOX, that is 3 months duration chemotherapy, followed by concurrent chemoradiation therapy, and then surgery, and then FOLFOX. So they lengthen the treatment with some systemic treatment, aforesaid the starting of chemoradiation therapy. So what's the outcome? You could see the pathological response rate almost double, more than the double. And you can see there is a difference between these two lines. So it also reflects the disease-free survival rate. So giving chemotherapy earlier than chemoradiation therapy might be an answer to delay this recurrence rate. Here comes with the Rapido trial that I am talking about, that the ESCO 2020 is the real game changer for rectal cancer management. Here they can see they have tried chemoradiation therapy followed by surgery and then chemotherapy, that is very standard arm, and another arm, short course radiation therapy followed by chemotherapy, then surgery. So you can see the difference. Then short course radiation therapy, there is a period for chemotherapy and then the surgery. And like the trial earlier I have shown, you could see the pathological response rate is quite high, and as well as the disease-free survival rate. So probably these are this area whether we are going forward. So intensify our treatment a bit earlier before the surgery. Now, in the era of 2020-21, can we avoid surgery? You can see after the neoadjuvant treatment, that is the concurrent CTRT, wait a bit. If we can really found a good clinical response, that is the complete clinical response. So can we avoid surgery? You could see that the local regional recurrence 2 years, only 25%. So out of 4, you can spare 3 patients from this surgery. And here you can see the distant recurrence is only 8% at 5 years. Long-term outcome, you could see the overall survival, 5 years overall survival without surgery, 85%. This is specific survival, more than that. So with this trial, so we can see that there is a subgroup where we can really avoid this surgery. But these are the issues which can be discussed with details in our next topics by our sir, Professor FM Kamaluddin sir. So I am not going in details, but just to get and highlight that there are some groups who can be spared from this surgery. So this is the development that I have discussed throughout the time, that since 1986 TME, in the short course chemoradiation therapy done by the Swedish group, and short course chemotherapy done by the Dutch group. And here comes the German group, long course chemotherapy. Again, this is the preoperative short course chemotherapy. And in this area, watch and wait. And now the 2020, we are looking forward this total neoadjuvant chemotherapy following the PRODIS trial and the Rapido trial. So I am at the end of my presentation. Just to conclude that, so this is the ESMO guidelines regarding the rectal cancer management. So besides NCCN, why I have brought these ESMO guidelines? Because you know that the ESMO are the medical oncologist domain groups. So if they establish the role of radiation oncologist, so you can be assured that there is a certain space of radiation therapy. So there is no question about these things. That's why intentionally I have brought these ESMO guidelines. So don't look these busy slides. I am not going in details with all these lines, because forget about these 2 groups. That is the very good groups, the earlier groups. Now come to this 3 lines. So these are the groups that the shaded lines that can be treated with surgery only. That's the T1, T2 group, higher up, higher rectal group or mid rectal group with a very good prognostic features. They can be they can be treated with surgery only. I am not going in these details with these topics. Let's see the intermediate disease group. Who are those intermediate disease group? There is the T3A and B. Its position is very low. So you need a good response to get a good surgical management. So your objective is to get a arterial resection, and the location is low. So if you really mean for a downstaging, you should go for long course radiation therapy. So if it is high with all these good features, you are looking for locoregional recurrence rate, so you can easily decide for short course radiation therapy. So that's why the location is very important. So if you are going for a good surgical outcome and the margin is you think that margin is a little bit plus minus, so you can consider for long course chemotherapy. Otherwise, you can easily consider the short course radiation therapy. So what about this? So this is the highlighted area for, you can see that short course radiation therapy and long course radiation therapy both are given there. It's up to you. You can choose any between these two. Now come to the locally advanced, a bit a further aggressive scenario, that the T3C and D very low, but still the levators not threatened, mesorectal fascia clear, and other groups that the high and midrectal group T3B, N1T, N1 and N2 disease. You could see that both options are there, but as the policy, as you have as know, the logic is there. If you need to downsize, you should go for long course, and if you need the locoregional recurrence rate, looking for locoregional recurrence rate, you can easily consider this short course therapy. And now the most ugliest group, that the T4 disease, T3 disease, mesorectal fascia involved, EMV positive, levator muscle straightened. So in this group, we can really consider about this total neoadjuvant therapy, that is long course chemotherapy or a bit intensified chemotherapy regimens. So that's all from me. I think we'll have a good discussions from Dr. Swarupa Mitra. Thank you all for your patient hearing. Thank you.
Thanks, Sumon. It was a great presentation, I will say, because rectal cancer is one of the most discussed issue now in the whole world of radiotherapy. So you have touched upon almost everything. As we have decided that some of the topics intentionally we will be discussing later. So I can see there are some questions in the chat box. Intentionally, I will be, what are the first, Arman, what are the treatment sequence recommended carcinoma, rectal sigmoid junction, and also CS sigmoid colon? Arman, it is more related to the colon. I mean, when it is a colon, sigmoid colon is a colon. So Swarupa, what is your take on rectosigmoid? How you differentiate rectos?
Further, am I audible, sir? Yes. So rectosigmoid, just as you said, sir, sigmoid, it comes in the colon. And in case if we are not giving radiation for sigmoid cancers at all, they are treated as colon cancer. But there are only a very few indications that post-surgery, if it is T4 or margins are positive, then a radiation is added. Otherwise, the sigmoid cancers, they do not have any role of radiation. The rectum, yes, as I think, let me first say this, Dr. Mostafa, it was an excellent presentation. I think very rarely I have seen so much has been incorporated and spoken so easily. It's an excellent presentation. So I think he has answered everything. In the rectum, yes, there is, everybody knows now it is the preoperative radiation chemotherapy which is required. And now it is the dilemma whether these days, it is the dilemma whether we go for long course radiation therapy preoperatively or the short course radiation therapy preoperatively. And if at all we go for the short course radiation therapy preoperatively, do we go for an immediate surgery or do we go for a delayed surgery? So these are the issues which we'll be looking for in the coming up questions which are coming up.
Okay, Swarupa. There is another question that how many cycles of chemotherapy recommended as adjuvant after neoadjuvant CTRT and surgery? Sumon.
So I have already addressed this issue. So if a good long course chemoradiation therapy is given, long course or whatever the radiation therapy, if the pathological specimens comes with pathological T3, T4 disease, N positive disease, you can consider adjuvant treatment. But as per the, I could say the ADO trial done by the Korean groups, the difference is 3 years disease-free survival, only 4 to 6%. So adjuvant chemotherapy, I think in a resource-strained country like Bangladesh, we really a bit need to be judicious regarding selecting this adjuvant therapy. So my take really be cautious before deciding the adjuvant chemotherapy, particularly
So,
for intermediate.
okay, Sumon, it is great to have Zahid here. It is a day of radiation oncology, but let us hear from a medical oncologist what they think. We have taken a good patient, very good chemoradiotherapy done, wonderful result, very good TME done. It was a T3N2 disease, but now very good response. Will you go for chemotherapy adjuvant or not, Zahid?
Oh, thank you, Kamal Bhai. I was hoping that I will hide today and just listen to the discussion. You've brought me out. Sumon, sorry, I've missed your first few minutes of discussion, but I was able to catch up, and that was really brilliant. You have brought these last 3-4 decades of research in the rectal cancer. And as been alluded a number of times, that then there are certain of issues that hasn't been resolved. And the very fundamental thing is the role of adjuvant chemotherapy in rectal cancer, because all the trials were fraught with two significant problems. One was the power issue in the statistics, and obviously the recruitment issue, staggered recruitment leading to lots of trials being halted prematurely. And obviously we know that an APR is a nasty operation, and after an APR, the clinical window to treat people within the adjuvant time can be very difficult. So bottom line, as you've already said, that all the trials did not prove any unequivocal benefit of adjuvant chemotherapy. And then that led to all these issues with reaching a consensus what to do. Now I can tell about UK. So in UK, if it's a stage 2 or below after neoadjuvant downstaging treatment, then we tend to avoid any adjuvant chemotherapy. And if patients are very keen, they can come for a discussion. We are happy to offer a chat, but from the clinically, we are not very keen to advise or recommend adjuvant chemotherapy. If it's a stage 3, again, we are happy to offer a discussion. And if the patients are willing, then yes, we offer them adjuvant chemotherapy, but we are very clear that this is not clinical evidence driven. It's more kind of two things. One is, as Kamal Bhai said, that if it's a locally advanced tumor at the time of diagnosis, then obviously you still remain a bit worried about the prognosis in spite of a really good downstaging. And from the patient perspective, if the patients are younger, then you might argue, remember we talked about this life expectancy issue, isn't it, last time? So if someone is 50 in UK, this person will have another 30 years to live. Okay, so the question is, the risk of recurrence will remain a worry for the remaining 30 years. So it's a risk benefit discussion. It's not a treatment recommended by clinical evidence. That's all I'm going to say.
Zahid, very well said. I think very important thing that we need to now today understand that there was a time, answer is yes or no. You give chemotherapy, you don't give chemotherapy. But today in 2021, we cannot say no, we cannot say yes. Because you see, after a very good treatment, it fails distally. Again, chemotherapy is not showing a wonderful, big and significant survival benefit. So you cannot flatly say no, you cannot readily say yes. As you said, the very important is the discussion. But what I believe, Zahid, in a country like us, in UK, it is very easy to make a discussion with the patient because they understand your language. But in a country like us, I think very important, first me need to be very convinced that what will be my take of, because when I start discussion, I know how to tailor it to bring the patient in favor of giving chemotherapy or putting him against chemotherapy. It is possible by a clinician. So if I am not very convinced about the chemotherapy, I may bring up the issues. If I am very much convinced, I will. So it is, I think, very important in a country like us that the clinician should know the strength and weakness of this recommendation. The cost of 6 months chemotherapy, financial, and the toxicity, and you say the APR, all these things, and the age of the patient, initial stage, all these things, then we should think that if we say, please go for it, they will go for it. They will sell their last piece of land, they will go for it. But we need to know actually what we are recommending. So I think in our country context, very important, we should go to the details of the study, like the TNT we'll be discussing next week. This Porridge and Rapido trial are wonderful trial. There is so many flaws in the trial, many limitations of the trial. We cannot just jump into the conclusion that we just go for TNT. It is not that easy 2 plus 2 math. So thanks, Zahid.
You're
So
welcome.
Orlol, there is a question about the timing. We will be intentionally, I'm keeping it for next week because these two things, TNT, watch and wait, and the timing I want to keep for next week. I bring up, practically, let me bring up my presentation again. So this point already Sumon discussed, but I want to discuss again that why we are very keen for radiotherapy in rectal cancer, because we have seen that TME is offering a wonderful local control. Yes, survival is not that wonderful. Local control is very good. Even in stage 3, only 19%. So the question is very logical that why we will be pushing for that. And another question is, if then can we avoid it? So if you look at the history that before 1990, there was no definite consensus even in USA for this addition of treatment with surgery. And in Europe, they were in favor of short course because of the local control, and Swedish trials shown overall benefit. But interestingly, I was looking at the two meta-analyses. Even individually, there was only one trial in OS, but these two meta-analyses were in favor of giving some OS with addition of radiotherapy. So we can say that this trial have given us some benefit of at least local control in addition to TME. But again, the non-oncologist, the surgeon colleagues may bring up the issue that giving radiation can cause some toxicity. So there was the issue of radiotherapy avoidance. And we are thankful to this MRC group who has solved this issue. Otherwise, today, maybe we will not be discussing about radiotherapy in rectal cancer. So they have shown that avoiding radiotherapy is not a good idea. So you can see that adding radiotherapy is giving a benefit not in OS, but in both the local recurrence and DFS. So the MRC group really proved that we should not be avoiding it. So thanks to MRC group. So as Sumon said, that even the TME is giving a wonderful local recurrence, local control. Yes, there is a rationale of adding radiotherapy with or without chemotherapy. But the question is about the toxicity. If you look at the paper of the 18 years outcome of this short course radiotherapy trial, you will see that the blame that went on radiotherapy was not actually the radiotherapy to be blamed. Main toxicity was from the TME because the excessive loss was there, and also the interpretation of the toxicity was a bit different. So finally, we, the surgeon and non-surgeon group, agreed that we will be going for combination. This already Sumon discussed short and long. And just for a recapitulation, if you look at the TROG and Polish trial, you can see the almost near outcome. But there is small difference. If you look at the Polish trial, you can see that there is a serious achievement of PCR and also very good result about the clearance of margin. But the sphincter preservation is totally equal, almost non-significant. It is quite surprising when we are getting a wonderful PCR, but the sphincter preservation is very comparable. Then if you look at if you dig into it, you will find the author explain that some of the surgeon of that study has violated the study principle, and they have not done the sphincter preservation, even there was some PCR. So this could be an answer that even after such a wonderful PCR, somebody may ask why the sphincter preservation was comparable. And if you look at the TROG trial, you can see that the survival is quite comparable, but slightly improved survival local control, a trend of improved local control rate in distal rectal disease. So we can say that what Sumon was telling, that these two trials, even it is, all trial cannot answer everything. That from these, we can say that location should be an issue when we select the modality, that whether it's a long course or short course, especially distal rectal, we can go for long course. And if it is a lower one, we can go for the short course, if it is near, it go for long course. And if it is a advanced disease CT4 or CRM positive, we should go for long course. And even with this today, we cannot say that we have enough data to clean cut recommend that when to give short course and when to give long course, because we are extrapolating data from different trials. So now my question to Sarupa, that what is your take? Do you advocate adjuvant radiotherapy in margin positive rectal cancer? Sarupa.
Yeah, yes, sir. Yes, sir. If the patient has not received radiation before the surgery, then, and if he comes out to be an R1, so probably he was basically a locally advanced patient and he was not probably correctly selected for surgery. So these are the patients who will require radiation. In our hospital, as a protocol, we are giving concomitant chemoradiotherapy to such patients. Now, if there is a patient who has received preoperative radiation, but even in spite of that, he is R1. So we do come across such patients. So these are the patients we discuss in the tumor board, and we could give about 10 to 12 grays of boost to the area if it can be identified by the surgeon. So any R1 resection, a radiation is given if a preoperative adequate dose radiation has not been given.
Sarupa, but if it is CRM positive, it is only CRM positive, then what will be your take?
No, if the CRM positive, only CRM positive, then we are not giving. Then definitely the chemotherapy needs to be given only for CRM positive. We may, if the patient do well, many times we have seen such patients, we have discussed in the tumor board, and at the end of the treatment, if the patient is very young, then sometimes we do go for a local radiation, maybe between the treatment, between the chemotherapy, but not as a rule. Actually, these are the patients who should not have been taken up. So if a patient, now again here it comes whether the patient selection, and like sir you said, and also Dr. Sumon said, the patient selection is a very important decision, whether we do a long course or a short course radiation. Now a mid-rectal tumor, a T3 or a T4, even T4, they can be taken up for a neoadjuvant chemoradiation long course or a short course radiation. But if it is a T4 tumor and it is located in the lower part, if the anus is involved, then these are the patients, then a short course radiation is not given and a long course CTRT is given. In spite of that, after that, if we have a CRM positive or R1 resection, then chemotherapy takes an upper hand. And it can be discussed in special cases if there is a gross disease, R1 disease, a boost can be given later on.
Thank you, Sarupa. This was a paper in Red Journal published, and they have made a, I mean, it was not intended to do, but they have seen that the post-operative radiotherapy group, there was no difference of with or without RT in CRM less than 1. They have shown that when it's 1 to 2 or more than 2, there was significant difference. And they concluded that there is no benefit of this. This was a edited about this study, and they have found that the comment they made was only 7% difference, and the p-value was 0.08, and the number of patients they have taken was not powered enough to come to a conclusion. And they also said that the comment they made was a subgroup analysis, which is not a very good way to come to a conclusion, and other data was in favor. And the interesting thing that that same Dutch group, after 1 year, published another paper, not a big series, but 96 patients, where they have said that CRM positive 1 millimeter will be benefited from post-operative radiotherapy. So as Sarupa was telling, if not given radiotherapy before giving radiotherapy post-op, area of huge debate and controversy, every institute can have their own protocol. Somebody may think, well, our chemo is enough. Somebody may think I will add radiation. Okay, that is no problem. But if you look at the MRC trial, you can see that when there is a margin positive, CRM positive, they have shown by giving adjuvant radiotherapy selective postoperative radiotherapy, compared to preoperative, there was a difference. And the hazard ratio was 0.6. So, well, these are not a conclusive thing, but I brought it up because I thought it is quite interesting to look into it because it is an unresolved issue. So now these were the very academic, debatable issue. Now my question is to Swarupa, what is your, sorry, I think Zahid has raised hand. Comment.
I was just going to ask that if you have a node positive post-op patient and it's R1, so you have the technically the question of both post-operative or adjuvant chemotherapy and adjuvant radiotherapy. So how do you sort that issue? How do you sequence these two treatment? I'm just interested to hear.
Yeah, yes. No, these are the patients we used to get. I think about 2 years back, there are plenty of such patients we used to get who were operated outside. They have received upfront surgery. Are you talking about upfront surgery?
I'm actually talking about both, whether they have new adjuvant radiotherapy or not. But if you have a node positive and,
yes.
and an R1 disease,
yes.
How do you address that?
Yeah, so if the patient has not received a radiation beforehand, that is, he has upfront surgery, then yes, we go for a radiation chemotherapy after the surgery. And most of the time, we sequence it, the radiation comes first, that is radiation chemotherapy, long course radiation chemotherapy, followed by adjuvant chemotherapy. But if surgery, radiation has been done, then we do not give radiation immediately. Node positive would not be a very good biology disease, so the chemotherapy is given first.
Yeah, our son said, you know, we radiation oncologists always sequence like that, and there's a positivity. We think we need to take care of the local treatment first, so we go for radiation first. We bring that around, and if it is a concurrent chemotherapy, it is a great thing too. So when there is a node or positive, but as she said, in cancer, you know, when there is a poor responder after chemotherapy, it is a good responder. Additional radiotherapy, because in all the discussion you have seen, it is giving local control. Radiation escalation is not giving us still not a clean-cut survival benefit. And if we are going to increase this area even after surgery, as Swarupa was telling, in very selective area, we don't know what we are buying, but we are sure that we are buying some toxicity. So we are quite cautious to think of second-time radiotherapy in this type of situation. Whatever we do at the beginning, if there is a node in the beginning, somebody go chase it higher dose to the node boost at the pre-op situation. But if it is already treated with radiation, probably not. Sumon, would you like to say anything?
Yes, I have some different inputs because the decision should be individualized. As you see, the PRODIS 23, the trial, they have tried chemotherapy earlier because the main challenge is the systemic relapse. So if the patient, assume this is a 27 years old patient, is a very low lying tumor, and so you are expecting a systemic relapse. So I think this is the condition where we should start it first. Because the local control by this time, so I think this is not a rule of thumb. So it is very judgmental and it should be individualized according to the severity of the patient, according to the condition.
Yeah, Sumon, very good said, well said, because you see, whenever we see the pre-op, post-op with surgery, we are having a wonderful local control, but they are failing distally. But again, we have seen giving additional adjuvant chemotherapy cannot control that distant metastasis. So this is a gray zone. I totally agree with you. As I said, I cannot disagree. As long as you have your logic in favor of your decision, it is justified because there is no right and wrong. More we are going, we are saying there is no right and well. Jahid, anything comment?
I was just going to say that even in the UK, we do not have any consensus across the centers. Is how Dr. Mitra has said that if the patient has preoperative radiotherapy, then yes, the role of radiotherapy becomes questionable. But if the patient hadn't had it, then it makes sense. But then you have to deal with the adjuvant window, the 12 weeks window where you have to try to fit in both treatment in somehow, which is a huge logistical challenge. So I was just going to say that some they go for a long course radiotherapy followed by chemotherapy, according to some of the trials. But in my center, we try to do a couple of rounds of chemotherapy first, and then radiotherapy, and then finish it off with chemotherapy as a sandwich treatment. But however, there isn't any consensus how to address this particular issue.
Thanks, Zahid. Sarupa, quick comment on you. I'm not talking about surgery. As a radiation oncologist, where do you see the importance of MRI?
MRI these days, we are not taking any patient for radiation without an MRI. MRI is a must because it not only delineates the tumor from the rectal wall, it tells us about how much the infiltration is there in the rectal wall. It tells us better about the nodes. It tells us about the mesorectal fascia and the EMVI also. So so we can better judge also the location of the tumor from the anal verge. So all these together, MRI is a must. We have developed our own protocol, rectal protocol, for reporting these MRI, and it is just a must. We cannot outdo this.
We need to look into this, that in case of NCCN guideline, huge details they have mentioned that what should be the criteria of pelvic MRI reporting. So if your radiologist is not reporting all these points, please go back that, hey, we have paid you full. So please complete the report and send it to me. So that is a point I wanted to bring up, and especially the CRM issue. So Sarupa, sorry. So are you going to make a question about course radiotherapy when they are giving a short course radiotherapy? Is there anything special they need to do, or just go for it?
Short course these days, we are, like I said, the selection of the patient is very important. After you have selected the patient, then there is no reason, and if you have the proper techniques, the IMRT, has to be very careful when you get a short course radiation. So the course radiation nowadays, we are getting a lot of patients very young. We are getting patients 18 years, 19 years, and we are amazed at it. So these are the patients who need to be, whether being short course or long course, the sperm banking is done, and we have to tell them about the infertility and the other factors which are related. And after that, once we start, we generally do it with IMRT and or IGRT after properly selecting the patients. So it's not really very, we are not too scared, because last 5 years we are doing short course radiation therapies, and we have not seen that the acute reactions or the long-term toxicity have been elevated. We haven't seen such patients, and we have become quite confident now with the short course.
Thanks, Sarupa. I was looking into the history of short course radiotherapy to see that the Dutch and Swedish trial, it was so old, but today this BRT, I was thinking that what should be our take, because all our centers are not fortunate to have IMRT. So I was looking at this paper. It is a paper from Spain, and they were giving a prospective outcome of the short course radiotherapy. They were looking actually in the frail old patients. But what is interesting in this paper, I found they have used 3D conformal radiotherapy and 4-field box technique, and their outcome was really wonderful. And so what I want to say that there is nothing very special even in short course 5x5, even the 5 are huge, but in rectal cancer it is only 5 fraction. You can just go with it even 3D CRT, because I believe this center really have IMRT facilities, but they have gone for it in Spain and they have published it. And I think this could be a good, interesting thing to know that even in shorts, we need to be a bit cautious, but not be super cautious. Without IGRT, I cannot do. It is not true, because you look at the history, it was the era of 2D and 3D when the short course emerged. So Sarupa, next question. Would you tailor your volume stage-wise? Say it is T3, T4.
Yes, a little maybe. Otherwise, all the same, or about 3 to 5 centimeters around the presacral areas, the internal iliac lymph nodes, the pelvic lymph nodes. But if it is a T4, then we take the external iliac also. So that is the only difference in the contouring and between the T and the T4.
Thank you. So, Sarupa, this is a paper I found in the Green Journal, and it is readily available. You can download it. It is a wonderful delineation guideline for rectal cancer. As she said, When it is T4, we need to think about addition of one more station. The debate is, shall we take inguinal or not? There is a big debate, and there are some papers that addition of inguinal didn't increase the survival. So majority of don't support taking inguinal. Some of the center, they go very near to NS or they prefer to take inguinal, but that is a debatable thing.
We are also
if you go to the whole paper, yeah,
we're taking the only when the NS is involved.
Exactly.
Otherwise, we are not.
Exactly. So this is a wonderful paper. I just brought the highlight because I'm going to discuss just for my colleagues that you can download this paper. And I think it is a very nicely written guideline for our contouring. So here I want to stop because already I am 10 minutes past from our scheduled time. Let me see, there are some questions there. How can we assess a complete clinical response, watch and wait? Dr. Asma, we keep this question for next week. So the question, all the presentation will be emailed. Now I would like to request our academic partner organization, thanks. Then we will go to the end of the program.
Thank you, sir, to allow me time to say something. First of all, I will show my honor to the Honorable Chairman, Professor Dr. M.A. Hai. I will also show my honor to you, sir. Also the overseas guest, Dr. Sharupa Mitra, and faculty, Dr. Mostafa Aziz Sumon. I would like to thank the Oncology Club to arrange such knowledge sharing program, and also thank the organizers to allow us Agvida Bangladesh as the scientific partner. It's always our pleasure from Jazz Group to attend some such programs. And we are already in different sectors attending such events. We are the organizing partner of Association of Cutaneous Surgeons of Bangladesh. Also, we are the organizing partner of Tricon, a hair society. Also, we are organizing partner of Aesthetic Dermatology Society of Bangladesh. I wish to share you the information that we Just Corporation not only import the life-saving drugs to serve the patient, but also we accept it our moral and social responsibility to be a part of such events. Again, I would thank the Oncology Club to allow us to be with you, and we will be pleased to be with the club in future programs also, if there is any chance. Thank you, everyone.
Thank you, Mr. Hussain. Thank you for your nice, kind words. So now we are almost at the end of the session. Next week, on Sunday, we will be talking about TNT, preferred timing between radiotherapy and surgery, watch and wait, and also some tips and tricks of radiotherapy in rectal cancer. And the most important attraction of next week is our guest speaker will be Professor Eloisio G. Morganti. He is a good friend of us, a global known person for rectal cancer management, and he agreed to be with us. I would like to request Sarupa and Zahid also be with us. And we are trying to get another colleague from India, because next week we want to make it more a discussion than a presentation, because we know there are many areas of debatable gray zone. A country like us cannot always deal with only evidence-based. We need some experience-based also. So when we borrow experience from these great people, this always help us. So I will request that everybody don't miss the next week's session. It will be a very interesting one. Now I request our president, Professor M.A. Haisa, to say a few words so that we can conclude the session. Sir, Haisa.
Thank you, Paul. Today I was late because of some personal favors from Ms. Soroba's comment. I could understand that presentation of Mostafa and Sumon was very excellent. Towards the discussions also about this. Thanks to everybody. Thanks to Jahid also for helping us from the end. Dr. Soroba all the time I will watch. She joins us. I'm happy to learn that next Sunday we'll get registered. Thank you all very much. Inshallah, we'll meet next Sunday. Bye-bye, everybody.
So thank you, sir. Thank you for your comment. So what we say that Oncology Club has been arranging is, and last 1 year, we realized that this is making a change among us. Every day we are learning by reading and also sharing experiences. It is not possible for one person to read everything, but it is very possible to listen to somebody. Sumon worked a whole week to make this half-an-hour presentation. So we are fortunate to listen everything in half an hour with what he gathered in 1 week. So that is the effort behind this initiative. It is not possible to get the precious time of Zahid or Sarupa because they are busy in their life. But Oncology Club is fortunate to get them under the same roof. So don't miss the opportunity to talk with them, ask them questions, share their experiences, borrow their knowledge, and explore it and use it in your own life. Oncology Club will be very happy when you will learn it and practice it, because no knowledge is of any value unless we use it. And once we use it, then we can ensure that we are giving the standard of care to our patient. And then we can say that our patients are getting the best, because we believe that irrespective of boundary and geography, every cancer patient deserves the best treatment, whether he is poor or rich, black or white. And the only barrier, I think, today is the knowledge, not the resource. Because the moment the drug comes, it comes to Bangladesh. But we don't know when to use, whom to use, and when not to use. So I will again request all our colleagues, please be serious about this program. Be a participant, not a listener. We like to have more questions. We like to have more interactions. We love that it is not me. You people will be asking questions to Zahid, Sarupa, and Alessio. Then it will be a real interaction. So as our president said, that we are thankful to our overseas faculties, Dr. Sarupa and Zahid. And definitely I will thank Sumon. He has done a good job. I know many sleepless nights he had to spend to prepare this presentation. Sumon, great job done. It was a really wonderful presentation. And finally, thank you to our academic partner for allowing us. And today it was near your presentation for participants. Thanks to all the participants. Hope we will have the same or more number. And invitation to Zahid and Sarupa to meet the great guy, Alessio Morganti. He is an amazing person. And you will love to meet him, I can tell you. And we will be discussing some real life challenges in rectal cancer and also the unresolved issues like TNT and the timing, because somebody still believes 3 months is a good time. Somebody believes, no need, you just go for it. So what is the best? Nobody knows. So it is better to talk to these great people. So until next week, stay safe. See you everybody next Sunday, same time with the same link we will be sending. Goodbye, everyone.